All right, let's dive into something you're absolutely going to see time and time again in your clinical practice. Recurrent aphthous stomatitis. You know, what pretty much everyone else just calls canker sores. Think of this as your high-yield, no-fluff guide on how to spot them, what else to think about, and exactly how to treat them. So, let's get right into it.
So, why are we talking about this? Why does this matter so much? Well, check out this number. Roughly 1 out of every 5 people in North America gets these things. That means you'll be diagnosing and treating this condition constantly. It's really not a question of if you'll see it, it's just a question of when and how many times a week.
So what is the official definition we're working with here? Well, recurrent aphthous stomatitis is all about repeated episodes of these really distinct, painful ulcers inside the mouth. The 2 keywords to lock in your brain are recurrent, which just means they come back, and discrete, meaning they're these well-defined sores, not just some vague, general inflammation.
To really get a handle on this, we're going to walk through it just like you would with a real patient. First, what does the classic canker sore look like? Then, we'll break down the different subtypes. After that, we'll go through the clinical workup, think about what else it could be, and finally, we'll climb the management ladder step by step.
Okay, section 1. The classic presentation. This is where it all starts, right? It's all about pattern recognition. So what are the key features you should be looking for?
You know, it's the combination of all these little details that really nails the diagnosis. You're looking for a round or oval ulcer, usually smaller than a centimeter, with that classic bright red halo surrounding a yellowish center. But here's the real kicker. Location is everything. These sores pop up almost exclusively on the soft, movable parts of the mouth, what we call the non-keratinized mucosa, like the inside of your cheeks, your lips, and under your tongue.
Okay, so you've identified a canker sore. What's next? Well, the next step is to classify it. See, not all RAS is created equal, and figuring out the subtype is super important for predicting how it's going to go, and of course, how you're going to treat it.
This table breaks it all down beautifully. The vast majority of cases you'll see are minor RAS, little painful ulcers that are gone in a week or 2 and don't leave a scar. Major RAS is the complete opposite. We're talking big, deep, incredibly painful sores that can hang around for months and often do leave scars. Then there's herpetiform, which looks like herpes because it's all these tiny little ulcers clustered together, but, and this is key, it isn't viral. And finally, severe RAS is just relentless. The patient is almost never free of ulcers.
All right, so you've seen the lesion, you've thought about the subtype. What's your actual plan? What's your systematic approach to the clinical workup?
It's a simple, pretty elegant 3-step process. You start with a great history, you confirm it with your physical exam, and only in very specific cases do you even need to think about labs or biopsy.
What's so great about these questions is that every single one helps you build your differential diagnosis. Asking about trauma, that's a classic trigger for simple RAS. Asking about systemic symptoms like a fever, that could point to something totally different, like a periodic fever syndrome. And asking about ulcers down below in the genital region, that's your critical screening question for Behçet syndrome. Every question has a purpose.
And here is a huge, practice-changing takeaway for you. For the vast majority of patients who walk in with classic minor canker sores, you do not need to order a single test. The diagnosis is made right then and there, with your history and exam. You only escalate to labs if the case is severe, weird, or just not getting better with treatment.
This brings us to one of the most important parts of the whole workup, the differential diagnosis. This is where you really have to put on your detective hat and think about all the lookalikes.
This is the question that should always be buzzing in the back of your mind. So, let's just quickly run through the biggest players you need to consider.
First up, the most common mimic, herpes simplex, the virus that causes cold sores. The #1 way to tell them apart? Location, location, location. Canker sores love that soft, movable tissue. Herpes, on the other hand, loves the firm, fixed tissue, like your hard palate and your gums. Plus, herpes usually starts with those classic little fluid-filled blisters or vesicles, which you just don't see with RAS.
Next, you have to have Behçet syndrome on your radar. This is a systemic vasculitis, and the absolute key is to look for signs outside the mouth. So if your patient also mentions they get recurrent genital ulcers, or they have eye inflammation or specific skin lesions, your suspicion for Behçet should go way, way up. This is a huge diagnosis you do not want to miss.
And finally, think about inflammatory bowel disease, especially Crohn's disease. Now, both can cause mouth ulcers, but the ulcers in Crohn's can have this really specific, linear, almost knife-cut appearance. And of course, you're going to want to ask about any GI symptoms, right? Like abdominal pain, diarrhea, that kind of thing.
Okay, you've made the diagnosis. Now for the final and, let's be honest, the most practical part. How do you actually treat this thing? Let's climb the management ladder.
The treatment approach for RAS is so wonderfully logical. It's stepwise. You start with the simple stuff, then you move to powerful topicals, you can use short bursts of systemic therapy for really bad flares, and only for the most severe, stubborn cases do you even think about chronic medications.
For most of your patients, high-potency topical corticosteroids are going to be your first-line treatment, and here are two fantastic options. Dexamethasone elixir is perfect when there are a bunch of sores. The patient can just swish it around and spit it out. But for just 1 or 2 specific ulcers, clobetasol gel is way more targeted. The key instruction for either one is to tell the patient not to eat or drink for about 30 minutes after using it. You want to give that medicine time to really soak in.
And for those really tough cases that just aren't responding, a short burst of oral prednisone can be a total lifesaver during a bad flare-up. Now, if you find a patient needs this all the time, that's your signal to think about a chronic steroid-sparing agent, something like colchicine or dapsone, to finally break that cycle of severe flares.
And finally, here's some really good news you can share with your patients. Even though these sores are incredibly annoying and painful, for the vast majority of people, RAS is a self-limited disease. That means the episodes tend to get less frequent and less severe over time. It basically just burns itself out with age.
And we'll end on this thought right here. Recognizing a simple canker sore, well, that's just step 1. The real art of medicine is knowing when it's a clue to something bigger. So the next time you see a mouth ulcer, ask yourself, what other signs am I going to look for? And what underlying systemic disease could I be the very first person to diagnose? Thanks so much for tuning in.